Hi, everybody. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Keys to Investigation, Implementation, Evaluation, Measurement. My name is Megan Shetterly, and I will be your moderator for this program, as well as one of the speakers. All materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. Rick Condravy, Melanie Motz, and myself are all patient safety advisors with the Patient Safety Authority. We interact with patient safety officers and other various healthcare staff to identify safety hazards, risks, and to reduce patient harm. Rick covers facilities in the Northwest, Mel covers the Southeast region, and I cover facilities in the Northeast region. So welcome. So today we are wrapping up our webinar series on Keys to Investigation. This is our final webinar. It's webinar number 8. All of the previous 7 webinars have been recorded, and the advisors have been providing links to that information to all of those recorded webinars on our roadmap, which Shelley is putting in the chat today, so you can grab a hold of that if you don't already have it. We are also offering 3 workshops in the spring of 2024. The first one is process mapping, timeline, and interviewing. We're actually offering that this month at 3 different sites at 3 different times throughout the state. And the registration link is available on that roadmap as well if you have not already registered for those. We have a workshop number 2, which is on causal statements and action planning. That is going to be in the month of April. We do have the dates and times available for that, as well as the locations, but we have not put out the registration link for workshop number 2 or workshop number 3, which is going to be on implementation, evaluation, and measurement. Again, the last 2 workshops, we have the dates, times, and locations. We just haven't put the registration links out, but the registration links for the process mapping, timeline, and interviewing is available on our roadmap. The benefits of all this is that we hope to improve your knowledge of the investigative process and offer you resources to use in your investigative efforts. So our objectives for today are to operationalize action planning, employ a range of analysis techniques to measure progress towards a desired goal and/or outcome, and create visual displays that reflect results of monitoring. So once your action plan has been vetted and it's been approved by your leadership and by your patient safety committee, you can now start to fix the problem. The implementation, the measurement, and the evaluation or monitoring piece are all going to work together, almost like gears in an engine or a machine. This is kind of the final phase of that investigation piece, where all of these are kind of going to be working in tandem with each other in this last phase. Now you're going to operationalize your plan. This is where implementation starts. And metaphorically, it's kind of like going across a bridge, and you're going from the thinking to the doing. So let's talk about the thinking part. If you remember, this slide was actually borrowed from webinar 7. And in webinar 7, when they were talking about causal statements and action planning, they had several healthcare examples that they were sharing with the audience. This is one of them. And this particular issue was about a situation where the defibrillator and the patches for the defibrillator were not compatible. And what they found in their investigative efforts were that there was a problem throughout their facility with this. So they came up with this action plan. So this plan has the issue, it has the risk reduction strategies, it has the responsible person, it has a due date, and it has measurement. When you're moving into that doing part and the implementation piece, you can still use this as your implementation guide or your implementation plan. But there are some opportunities. You could edit this a little bit. You might want to put, instead of just the due date, you may want to add a particular column that says that this is today's date. and then what the deadline or due date is, the actual date. So for instance, this first one says the due date is today. You might put that, you know, the start date is today, March 7th, and that the due date or the deadline is also March 7th. Similarly, if you move down to like that third row where it says 30 days, you could put that today's date is March 7th, and the due date or the deadline would be perhaps April 7th. So it's a tool, it's a something that you could format, change, edit to meet your needs. But what I would suggest to you is you may want to also consider a project plan. It could complement that action plan, or it could replace it as far as your implementation plan. There are several out there that you can choose from. One is called a Gantt chart. There are some free downloadable templates that you can get, and actually there's one in the resource tab at the end of this webinar presentation that has free downloadable templates that you can actually plug in your project plan or your action plan into that. What I would say to you is, you know, you can put the same things that you had in that action plan. So on the left-hand side, you might want to put whatever the task is or the strategy is. And then as you move across and you look horizontally, you may want to put your timeline for when you want that to happen. Again, starting with today's date, what the deadline is, and then kind of this timeline of when you want things to happen. The other thing that you can insert in here, which is kind of nice, and it's a visual representation, so it's kind of like a roadmap for you, is you can color code things. You can put things in like color coding, you started it as green, it's in progress maybe as yellow, so you're going to be changing those colors on the map. It's completed, could be blue highlights, or if it's stalled for any reason or you had to pause it, that may be another color, maybe pink or purple or something of that nature. I like color coding a lot, but I think if you are going to use color coding, you're going to have a legend, because you're likely going to have other people, and you should have other people looking at this as well. You'll need to be sharing this with the rest of your team. So there needs to be a project leader or a champion who's going to be overseeing this, a liaison between that leadership and the staff who's going to be sharing this information. So how are you going to get that implementation map in a place that you can share that with others so they know what's going on? Is it in progress? Has it been stalled? Do we have to extend things? You as the project leader or the champion are going to be facilitating that change process and monitoring it as it goes along. So let me just give you a for instance. When we were talking about the action plan that we had borrowed from the previous webinar that was talking about that incompatibility and the strategies that they were putting forward to make sure that they had consistency with their defibrillators, they were trying to purchase or get defibrillators that were consistently the same across the board throughout their facility. And they said that they wanted to procure that within 30 days. Well, supply and demand, there may be a problem there. So instead of 30 days, they may have to go back and elongate that timeline from 30 days to 60 days. And you have to be able to share that with the rest of your team so they know what's going on. So that document, that project plan, that Gantt chart, the implementation plan, whatever you want to call it, is going to be a living document. And again, you're going to have the implementation, the measurement, and the monitoring kind of constantly happening. Those gears are constantly turning. Once you find that you're ready for spread, again, you're going to have to notify the rest of the team. And in this situation, when we're talking about the defibrillators, this is kind of like a one-stop shopping. Like, you want to make sure across the board, the urgency is probably greater here for getting this all done at the same time. But you may have other situations where maybe you're doing something like communication tools from Team Steps, where you're starting with one department or one area, and then you're measuring that and monitoring that to see if you're ready for spread. And then again, you would have to measure it though to see if you are ready to spread from, say, med-surg to move on to ICU to the ER or what have you. And this is kind of where that measurement piece comes into place. And Rick is going to talk to you more about measurement in terms of this whole cycle of implementation, measurement, and evaluation. So Rick, I'm going to turn it over to you.
Getting back to my presentation, early on in her presentation, Megan made reference to webinar 7, webinar that preceded this particular one. And that webinar addressed the generation of causal statements and how causal statements form the basis for your action plan. And what I found interesting was that the very last comment that was made during that webinar, webinar 7, the closing remarks, prior to the closing remarks, was the response to a question posed to the presenters, which asked, how do we know that our action plan is working? Well, you measure it. And this is, how you determine what your that your action plan is effective. Now, that question serves as a nice segue into my portion of today's presentation involving the follow-up phase of the investigation process. Bob Yarnish, the webinar 7's last presenter, mentioned that there were 4 tenets of action planning, the second of which is that the key elements of your action plan need to be measurable. And measurability also came up as part of the discussion of SMART goals, with SMART being an acronym for specific, measurable, achievable, relevant, and time-bound. So if you want your action plan to be successful, you would need to measure the effectiveness of the actions that you put into place, and meaning that you want to hit that bullseye. So before I get into the discussion of the determination of a measurement strategy, I would like to review a few tips for effective measurement, which are choosing a numerator and denominator, selecting samples, setting timeframes, and assigning responsibility. First, in regard to choosing a numerator and denominator, numerator in your measure of success is defined as the number of events being measured. In other words, what are you measuring? For example, the number of falls that resulted in a hip fracture in patients over 70. The denominator is defined as all the opportunities in which the event could have occurred. In other words, the population from which to collect the information. And the example of this would be the total number of patients on a unit who are over the age of 70. Having the appropriate numerator and denominator is very important. And I have to think back, but early on in my career, I experienced an interesting situation involving the pathology department of the hospital where I was working at the time. One of my areas of oversight involved the graduate medical education department, and one of the duties as part of that function was the completion of accreditation surveys for the 4 residency programs that we had at the hospital at that time. One of the requirements pertained to maintaining a certain autopsy rate to qualify as a residency site, and our facility autopsy rate suddenly and significantly decreased. So I started asking questions and determined that the new administrative director of the pathology department was using the number of discharges as the denominator rather than the number of deaths to calculate the autopsy rate. And as you know, you only do autopsies on deceased patients. So it took a little bit of explaining and investigation, but we figured out why that had occurred. And then with regard to the next measurement tip, selecting samples, I wanted to mention that there are actually 2 components of selecting samples. The first being sample size methodology, and the second being sample size calculation. Now, the sample size calculation can directly influence your measurement findings. So meaning a very small sample size can undermine the validity of your study. Large sample sizes tend to transform small differences into statistically significant findings, which is what you want. Sample size can affect the reliability of a study. A larger sample size can increase the reliability of the study by reducing the chance of random error, making the results more representative of the population under review. So if I remember my biostatistics course information correctly, a sample size of 30 is fairly common among statistical analysis. The general rule of thumb is that I recall is for a population size of fewer than 30 cases, the sample should be 100% of the cases involved in the study. For a population size of 30 to 100, a sample size of 30 is recommended. for a population size of 100 to 550 cases is recommended. And then for a population size greater than 570 case reviews are recommended. So now what you want to avoid in the is sampling bias, which occurs when a sample is collected in such a way that some members of the intended population have a lower or higher sampling probability than others. This results in a biased sample of a population in which all individuals were not equally likely to have been selected. A biased sample is the result of collecting a sample from a population that is not random. The sample is biased because the data collection has a higher chance of occurring compared to other possible data outcomes. An example of sampling bias in healthcare might be observing patients in the emergency department during the daylight shift as part of a study, because that's when the person collecting the data or the person assigned to do the study is available. We know that emergency departments are open 24/7, and the results of this study may be skewed in a certain direction because patients who arrive in the middle of the night are significantly different usually than the patients who arrive in the middle of the day. A famous example of sampling bias occurred in the 1948 election. And by the way, Mel and Megan, I was not around for that election, so I wasn't around for quite a bit of time afterwards. But the 1948 election was between Dewey and Truman, and there was a telephone survey that was conducted through a national survey team that called households throughout the nation during the day to get their feedback about what candidate they were choosing to vote for in this presidential election. And the overwhelming results were that Thomas Dewey, one of the candidates, was going to win a landslide election over Harry S. Truman. And newspapers relied on this information, went out to print their headlines for the next day. And lo and behold, what happened was that Dewey lost to Truman, and Truman became our 33rd president as a result. And the expectation was that Dewey was going to win. Well, that was a flawed study in the sense that their sampling only focused on people that were home during the day, not people that maybe were working and came home later, et cetera. They weren't getting a representative sample of the true population that was voting in that particular election. So it's very important to remember that that biases can lead to false conclusions, which might be misleading. Bias studies are not reproducible and will affect the credibility and validity of your work. So how do you avoid sampling bias? This is where sampling methodology comes into play. The most common sampling methodologies are by far random sampling, the most commonly used, and then two other less commonly used, but stratified sampling and cluster sampling, which use random sampling in their process, but stratified sampling involves having the total population divided into smaller groups, by categories like by age, gender, et cetera. And then you use random sampling to abstract, your samples from that particular process. And then cluster sampling, again, selecting certain groups from the entire population and just focusing in on those through random sampling. But by far the most common is random sampling, where the researcher defines the population, chooses the sample size, and then determines the population units, assigns a numerical value, selects the random values, and then identifies the sample. And there are actually computer apps out there now that can help with this process in terms of selecting the numerical values when you're doing a random sampling and all. So that's where the methodology comes in as part of the sampling process. And then our third tip which has probably been discussed, several times in terms of the importance of establishing timeframes, but you need to have a deadline. But it needs to be realistic and achievable. And Megan just talked about how you might have to go back and readjust based on, your action plan and what your expectations were for being moving forward, trying to achieve it. Um, uh, you know, you can achieve measurement goals if in the times allotted. You need to really ask yourself. Setting a deadline brings focus to the project, and really the time frame depends on the situation. Some actions, we found can be addressed immediately. Other actions take a little bit longer to implement or ongoing. And then the final and fourth measurement tip involves assigning responsibility for completing a specific action. This is an important step because it creates ownership for addressing the problem and ensures that to a significant degree, that that the uh, measurement processes that are in place will be monitored and completed. So what we need to do is determine a measurement strategy. Um, and we need to determine what will be measured. How will you measure? But how long will it be measured? How often will it be measured? And what is the expected compliance? Also, you need to consider who is responsible for this and where does it get reported? Who needs to know? Does leadership become part of that communication process, frontline staff? And then what committees are involved in receiving the information? Where do you make these results available? Well, knowing the results have an impact. Most likely, staff will be more apt to continue with the process redesign if you see that it is working. Leadership will continue to support the resources dedicated to the action plan if success is being achieved. So next slide. I have, moving forward here, I have actually two examples where we could apply, this information in a chart format and everything. But as we indicated, we're far along in the investigation process. We're at the follow-up phase. And so we have our uh, uh, causal statements are identified as the issue in this particular chart. And then we have risk reduction strategies listed. So our first causal statement for an event, which I abstracted from one of our education programs, actually is a situation where a patient complained of feeling woozy post-procedure. His nurse checked his vitals and notified the nurse anesthetist. The nurse treating the patient received verbal orders for ephedrine, and the nurses went to gather medications and supplies. She was not aware, though, that there was a drug shortage, and the epinephrine was now in vials, while the ephedrine was now in ampules. And the medication that was drawn was the incorrect medication. And at that point, they weren't aware, but the patient then complained of feeling flush, and then an investigation was begun. So what we have here are two causal statements as issues that were generated in regard to that investigation. You have the drug shortage led to an unusual formulation of ephedrine and epinephrine in stock, and the wrong medication was selected and administered. So risk reduction strategy associated with that particular causal statement is alerts will be placed on storage bins when the different formulation, that is packaging size and concentration, is substituted. And then install automated dispensing cabinets for medication distribution. And so you see some low leverage as well as some higher leverage interaction there listed with the actual action plan. And then the second issue, ephedrine and epinephrine are known look-alike, sound-alike medication names in the literature. These medications were stored next to each other, and the incorrect medication was selected and administered. And to address that, the risk reduction strategies, of which there are two, identify look-alike and sound-alike medication currently kept in stock and develop a list, and then use tall man lettering to implement it for if epinephrine and ephedrine bin labeling. And you'll see there that this chart is incomplete because you want to come up with some measurements based on the questions that were posed on slide 11. You can take a look at those various questions and what actually you need to determine what your measurement strategies are. You see along the upper portion of the chart that's listed here in this slide, we have those action statements. Alerts will be placed on storage bins, installing automated dispensing cabinets, identifying look-alike, sound-alike medications, and then tall man lettering implementation and all. And then, the various things that will be measured as a result of each of those actions that are being recommended and carried forward. For the alerts being placed on the storage bins, when the medication orders are placed, substitute meds are noted, and the director of nursing will use the list to inspect the med storage area. And then you have install automated dispensing cabinets. There's really nothing here to measure here, but you could document the date that the cabinet was installed. Identify look-alike, sound-alike medications. Again, you're developing a list, and when that list is completed, it would be dated, and then you could review it annually as part of the action that's recommended moving forward. And then with tall man lettering, tall man lettering is implemented and labels changed, and then you could keep track of the dates that those are done. You can monitor how long you want to continue with these measures that you've adopted as a result of the action plan that was created with regard to this particular event. And so, you have a tracking mechanism that's available, for you. And what we have here on this slide is a continuation of this particular example event. And it's for the slide 12 was not complete, but you could have a nice summary document here with in chart form where you again have the issues that are identified in the risk reduction strategies, but you also include the responsible person, the date that's involved, and then the various measures that you have in place to monitor the action plan that was put into place to address this particular issue. I have a second example, which has a little bit more detail in terms of an actual monitoring measurement that you track over time and you could display as part of an ongoing effort to monitor the effectiveness of your action plan. Now, in this particular case, it involves a patient fall. So patient determined to be high risk for fall with injury. Call light was not placed within reach upon the last interaction with the staff. Patient needed to go to the bathroom after receiving diuretic and got up without assistance and fell. So the issue is the call light was not placed within the patient's reach. Now there's probably a multitude of different aspects of facilities fall reduction program, but this is one particular item that facilities focus on in terms of being able to be alerted that the patient needs to go to the bathroom because a lot of the falls that occur are bathroom related. So they're focusing in on the call light being placed within the patient's reach. The risk reduction strategy is that call light placement for all patients will be verified with every patient interaction. The responsible person is the director of the unit, and then it's to start immediately. And the measure is going to be weekly audits of 10 patients that observe whether the call bell was within their reach. What we have on the next slide is the data collection process involved with this particular action plan. And the data snapshot focuses in on week 4 of this monitoring process. And the 10 patient are listed 1 through 10, and the compliance with the call bell being in reach at the time that the patient was observed is listed as either being the call bell being present or or within the reach of the patient or not being in reach of the patient. And for week 4, there was a 90% compliance. And the chart, the cumulative data, provides a summary of each week. And you see, starting with week 1, there was a 60% compliance. Week 2, 70% compliance. There was 100% compliance in week 3, and week 4 dropped a little bit to 90%. And then from weeks 5 through 10, you see that there was 100% compliance. And to the right, you see the run chart, which provides a real nice depiction of, how well this particular aspect of the action plan for fall prevention for this particular event is working. Somehow week 1 dropped off, but starting with week 2, you see the 7 events, observations made where there was compliance with the call bell being in reach of the patient. You go up to week 3 with the 10 and back down to 9. And then the rest, you can change, in this particular case, it doesn't correlate with the actual summary of the cumulative data, but this is just to show that how you can track and show this on an ongoing basis at maybe your patient safety committee meeting or senior leadership about how you're addressing this particular issue. And so you track that as the data collection process. You can correlate that with the number of patient falls. And again, too, we have weeks 1 through 10 represented, but what is listed in the the right column of the patient falls weekly data summary is listing the number of falls for that particular week. And you see early on, you have 1 during week 1, you have 2 during week 2, drops down to 1 during weeks 3 and 4, and then 0 during the remainder of the 10-week study in this particular case. And I'm sure this will continue to go on, but right now you have a nice depiction of how the focus on the placement of the call bell for the patient has worked to reduce the number of falls during this time period. Because in the eyes of this particular facility, this was something that they felt was directly related to the occurrence of falls within their organization. So we have these examples, to sort of demonstrate how you can graphically or through various charts show, your progress through this journey of reducing or totally eliminating the occurrence of certain types of events. So with that in mind, I'd like to turn the program over to Mel, who is going to focus her concentrate her presentation on a discussion of a deeper review of monitoring the effectiveness of your project plan. Mel?
Thank you, Rick. Thank you, everybody, for joining us today. So I'm going to close out by talking about just the overall evaluation. Megan hit on it, Rick hit on it. I'm going to say it again. At this point of the process, of an investigation process, you have your action plan, you're implementing it, you have your measurement strategies, and it's really all working together. You should be constantly evaluating your project. Always be evaluating to get to that end goal. You want that end goal to be successful. So in order to, create success, you want to always be evaluating. So you have that action plan, it's been established. You have a measurement strategy or several measurement strategies, as Rick explained, in place. So it's important to continually evaluate the project plan. So I think what's important, and this is going to be dependent upon the type of facility you are, you want to make sure you start small or have a pilot program before you go big, or as Megan said earlier, ready for spread. I really like that. Before you go, hospital-wide or facility-wide. And this is going to be dependent upon what you are working on. Is there a new pre-op phone call process? Are you implementing teach back? Is there a new discharge process? You might want to start at, a unit level or, one of the outpatient surgery departments first to experiment and see how it goes. This allows you to make changes and tweaks as needed. It's really an experimental time. So there's a good chance something will need to be adjusted. I know everybody on this call today you all are very smart, intelligent people. I think we all realize that we don't always have control over how things go. So we want to make sure that we keep an open mind when evaluating these projects. So sometimes a well thought plan doesn't go as planned. So let's talk about how you can follow through on that well thought out plan to ensure it is successful. So first thing, you want to make sure that you're measuring the effectiveness. Are you following through on the measurement strategies? Are you involving others? You know, as patient safety professionals, you know, we all have a lot on our plates, and it's important that, you know, this is an interdisciplinary approach, that, you know, you are involving IT and pharmacy and lab if necessary. And of course, it's going to be dependent upon the project that you're working on. And being sure to delegate, you know, include staff, include, you know, some of your coordinators. Reporting findings to appropriate group in your facility. Best place, you know, to start is your patient safety committee. You know, as hospitals, you're meeting on a monthly basis and talking pretty regularly. And you can utilize some of your patient safety committee to help you with it, you know, work through this project. Does the action plan work? You want to constantly, I feel like I'm going to repeat myself over and over here, but you want to constantly be reevaluating and make changes as needed in order to make sure that it is successful. Tracking your progress. You know, you are ready for, you know, implementation. You're ready, you're on your way. And, you know, do you have a checklist? Are you using, you know, that Gantt chart? Do you have another way to organize yourself to ensure you're getting everything done that you want to? Is there any follow-up? Do you need leadership and support? You know, if dates aren't being met for one reason or another. Megan mentioned earlier, supply and demand. I know we live in a world of, you know, drug shortages, back orders. This is, you know, this is realistic, and, you know, that's why it's important. And Rick said it, you want to make sure that you're making your timelines, you know, reachable, you know, in order to make sure it is successful. And sometimes you may have to push things back, or, you know, prioritize one unit over another, you know, based upon census and what's going on. You know, we know that you're all busy, most likely wearing multiple hats. So, you know, time blocking for this project, I think, is really important. And utilizing that Gantt chart will really help you stay organized and intentional in following through and being successful in implementing your action plans. And just to speak to that, and I think Megan mentioned it, at the end of this presentation, under our resources, there is a great reference to a Gantt chart, more information on the Gantt chart if you are not familiar with them, or if you'd like to start utilizing them. So now, over the next couple slides, I'm just going to share some sample findings and some examples. You know, this is just to give you a little background. This event specifically, this was an RCA was performed on this. There was a change in the reference lab from one lab, main lab, let's say Quest, to LabCorp. And the lab system was updated for this specific virus test to indicate that a red top was preferred. But in the EMR, in Epic, it was not updated and still indicated the yellow top was preferred. So what happened is the blood specimen was collected in the red top, and so the lab wasn't processed. So this caused a delay in diagnosis for this patient, a pretty significant delay. So the action plan that was put into place was to develop a procedure to cross-check updates to the lab system and with Epic to ensure consistency. And the responsibility of this fell on the lab director and IT. So these are just some sample findings where, you know, you could see here the number of preferred tube top colors updated in the lab system, and then percentage of tube top colors correctly matched in Epic. And you can see, we're looking over the months. So May and June, we were great. We had 100% compliance. And then boom, July and August, we're not really sure. The tech resigned. So this is a really great example of how action plans can start great, but an unanticipated event, okay, an employee leaving, can destroy all your hard work. So if someone owns a process, how can we make sure that it's addressed if they leave or are hit by a bus? Okay, how can you build in making more people accountable for this process and maybe just not one person? So this is just an example of, okay, we have to make some tweaks. This was working, but now it's not. And we don't have the 100% compliance that we need. Another example, this is, you all have heard of alarm fatigue or alert fatigue. Some of you I know probably have electronic medical records. So this is just showing, this actually should say quarter, not month, but looking at the number of lab alerts in quarter 3 of 2020 compared to quarter 4. So you could see in quarter 3, there were 110 lab alerts sent to the clinical team in Epic. And then in quarter 4, there's 430. 430, probably overdoing it. Little alarm fatigue, alert fatigue here, I should say. So, you always want to consider how's staff going to react to this, the 4 times the number of alerts. They're probably complaining to you at some point, and they're probably not reading them and clicking through them. So, you want to try to avoid things like this. This is a point in time like, this isn't working. We need to reevaluate, what changed between quarter 3 and quarter 4. How can we fix this? Just to tie it back to Rick, a nice successful example, this was, the issue was, the call light was not placed within patient's reach. So therefore, there's an increase in patient falls. And the risk reduction strategy was to verify that the call lights placement for all patients will be verified with every interaction. And it was the responsibility of the director of the unit to do weekly audits of 10 patients at the call bells when within reach. So there's this great run chart to show, this is what we've been auditing. This is how many patient falls since we started. And you can see, we really started, doing great come week 5, and there were no patient falls. So this is success, right? This action plan, this measurement strategy, it worked. So this is something you want to make sure that you are communicating, like I mentioned earlier, to your patient safety committee. You want to show staff this. You may want to, employ this, elsewhere in the facility. So a great example of success. Moving on, some of you may have heard of this. This is the PDSA cycle, otherwise known as the Plan, Do, Study, Act. And it's a simple, easy to understand cycle to test your action plan, implementation, and measurement strategies before rolling out on a larger scale. I really like this tool. This strategy can be applied to everyday tasks you perform in your organization. You're probably doing it every day and not even realizing it. So really, it's very simple. Planning, you're setting goals. The do is you're implementing. Study, you're analyzing what's happening. And act is you're making changes. So this, you can get more information about this from the AHRQ. I did note it in our resources section at the end of the presentation. It has great examples on how to tweak your action plan accordingly using this method. So it actually walks you through how they started and what they ended up doing in order to make it successful. And it specifically touches base on they tested, when to give patients patient satisfaction surveys, and also the use of teach back by physicians. So this is actually a worksheet that is on their website. And again, the references at the end of the presentation. And it's just like I don't know, I think it's such a nice, simple way. I think we can get very complicated with how we measure things and what we're doing. And sometimes this is a good place to start. And it's a great way to really kind of evaluate how you're doing. So Simply, I plan to. Nice, concise statement you want to put in there. I hope this produces, what do you want to measure? What's the outcome you're looking for? Steps to execute. What are the steps and what's the time limit? Okay. Always making sure that you create some type of deadline, whether it is today, 4 hours from now, or 3 months from now. What did you observe? What reactions did you observe from staff? Did everything go as planned? And act, what did you conclude from this? Are you going to do something different? Did it work? Or is it time to implement? And as what Megan said, ready for spread. Is it ready? This is good. We got this. We know this works, and we're ready to communicate that. Feedback loop, we say this often, and you hear it all the time: communication, communication, communication. Where are these results going? You put a lot of work into these action plans and implementations and creating measurement strategies, and you want to make sure you share them and be proud of them. So who needs to know? Leadership needs to know, your frontline staff needs to know, and your committees. You want to, keep those lines of communication open from the top to the bottom. Leadership, they can provide support. They can support resources dedicated to the action plan if success is being achieved. Staff, knowing the results can make an impact. They're more likely to continue with process redesign if they can see that it's working. And how are you presenting this information? We all process information differently. Some of us like to read, some of us are auditory, some of us are visual. I know I'm a very visual person, so seeing charts or a dashboard is really, it speaks to me. That run chart of seeing that we had no patient falls in weeks 5 through 10. That's awesome. And some people, if you're a small facility, you might have an intranet, where you post results. Are you using email? Do you have a staff binder? Are you talking about it at staff meetings? Are you making posters? Do you have a unit bulletin board? I think there's so many different ways to communicate, and I think as a facility, you need to figure out, what your culture is and what is the most effective way to communicate positive results. Monitoring, consider a 6-month review of plan. Was everything completed? Do you need to revisit this action plan? Hopefully, you are sustaining change, and that's always the goal. And sometimes we do. Sometimes we do great for those 3 or 4 months if we're doing audits, and then people drift. It's natural, and they lose focus. So it's always good to bring back some of those projects. Maybe it turned into, there was so much success, and the next bullet point here, the measurement may be passed on to another group, for example, performance improvement. So, if you do something as a pilot project on your unit and it went very well, and, performance improvements like, hey, we're going to take this over and we're going to, employ this elsewhere, it's okay to bring back. There's always opportunities for improvement, and sometimes it's good to recycle a performance improvement project. And more importantly, you want to make sure you only do that after the action plan is complete and that it shows improvement and that change has been effective. And lastly, just to finish off our presentation, other opportunities for improvement. You all know this. You have probably been involved in some type of performance improvement projects or audits. Keep a running a list of other issues identified. So, if you're using the Plan, Do, Study, Act, and you're talking to staff and doing observations, and you're like, they don't seem, they're not quite sure what to do here, and talk to them about that and take a note of that. That's potentially another performance improvement project. The lab example I gave you earlier with the red top and yellow top tubes, they had a reference lab, this is where labs got sent out. The staff didn't know what labs got sent out and which ones were done in-house. That right there, that's an opportunity for improvement. Making a list and making sure that that's updated so they know, if it's taking a little bit of time for, a lab result to come back, they might know that because, oh, that's a send out lab. And that may change, contracts change, with reference labs for one reason or another. But keep a running list of those other issues identified. And again, follow up on them, create accountability, somebody, that's responsible for it. And of course, that timeline. What's your target date to identify those issues? And that's how we can continually improve the healthcare we provide our patients. Here are the resources that I mentioned.
Thanks, Mel. That concludes the slide presentation portion of our program. And it looks like we have about 8 minutes left, so I'd like to begin our question and answer period. So if you have questions, please type them in the chat box. It's found in the lower right of your screen, and then direct the questions to all panelists. And then we're going to try to answer as many questions as we can. If you don't see the chat box, click on the chat bubble at the bottom of your screen, and you should see that chat box open up for you. So Mel and Rick, I'm looking over. I don't see any questions. Do you?
I don't, not at this time.
Yeah. So, Rick, here is a question though, that I have. Does a larger sample size reduce the potential for bias?
Gee, generally no. When you think about it, now I have to think back to my presentation, but I talked about the two components of sampling, and one was the sampling methodology, and the other was the sampling calculation. And the sample size has more to do with the calculation, and that's really not going to impact the causing any bias. I think the true focus should be with the methodology. So if you have a random sampling process in place, that should address the elimination of any bias and all.
Mm-hmm.
And I just thought of something else when you asked that question, and I could probably go back to my fall example with where they were doing observational studies to see if the call bell was in place. Years and years ago, when I worked in the hospital setting, and we would do different studies, we were always concerned about observational bias, meaning that if we were studying hand washing and the infection preventionists showed up, I think people were a little bit more focused on their technique. And I think Bob tells the story that when he was on the regulatory side of the DOH's licensure inspections and all, he could usually tell which individuals weren't used to hand washing because they would have these exaggerated motions. And so one of the things that that comes up in terms of observational bias would be oh God, I'm trying to remember what's referred to as masking. And it's like showing up on the unit with communicating that you're there for one thing, but you're actually going to be monitoring something else. And that's what a lot of the DOH surveyors and the Joint Commission surveyors do. Sometimes they're saying that they're looking at one thing, but while they're there, they're also observing other things related to other aspects of the survey that they're conducting and all. So, but the answer to the original question is that, really focus on your sampling methodology. Increasing the sample size would not necessarily create bias.
Okay, thank you. One of the other things I thought about too was, and I was talking about earlier about project plan or the Gantt chart. Again, this really, can be used for anything. It doesn't have to just be used for the implementation, measurement, and monitoring phase, although I think that's going to be very helpful to people when they get to that phase. Quite honestly, you could probably use it for, any and all phases of your investigative process in terms of like, your meetings and, how you have those set up, and kind of put that on your timeline as well. And any other, goals or outcomes that you want to achieve in any of those specific phases that you could kind of set deadlines for yourself. And again, remember, that's a living document. You're probably going to be moving some of those things around depending on what's going on. You may move things up or you may move things back, depending on the situation. But you can also use that for several projects that you have going on. I mean, if you are the person who's like the quality director or the person who's in charge of like multiple projects, it could be useful, especially if you're in a bigger facility, to see like what resources are being allocated for all these different projects at the same time. Because what you may find is that, oh, maybe we need to pause this one project. It's not as urgent as what we have going on here with this response and action plan that we're putting in place. And so you may have to kind of juggle things around, and it helps to give you like that big picture. And not only you, I think, as the director, but the rest of the team. And I think that we were all saying that, like that shared mental model. Everybody needs to know what's going on, from the frontline staff to leadership. Leadership needs to know they're going to be able to provide you with resources if you do need to overcome some hurdles or you're having some stalled activity with your project. They need to know what the process is and what's going on. But also frontline staff, you need to be able to give them feedback and see where you're at with the process and how you're progressing. And certainly when you're meeting those hurdles, let them know, because that feedback loop is so important. Because if they know it's working, they're more likely to continue to do it, and celebrate those successes. But again, all of this stuff is working together. The implementation, the measurement, the monitoring, it is just like gears in a machine. You are constantly doing all of them in tandem, really. It's like a living kind of process until you get to your desired goals and outcome. And then you may be spreading it again to another area, another campus, if you're a big system or what have you. So I think if you do have any questions and, maybe you just don't feel comfortable even asking them in this forum at this webinar, certainly reach out to your advisor. Again, I'm just going to reinforce that we have some workshops coming up. If you're interested, please get access to that roadmap. Ask your advisor for the roadmap if you don't have it, because there are links to the recorded webinars as well as the workshops. And if you are attending the workshops, I'm just going to throw this out there. I think it would probably be in your benefit to re-listen. If you did listen, or if you didn't listen at all, listen to those recorded webinars for those respective workshops. So if it's on process mapping, timelines, which is the one coming up, listen to that before you actually attend the workshop. That might be helpful to you. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or the certificate of continuing education, please feel free to direct any of those inquiries to Shelley Meixel,